Well, I'm hoping our next speaker will educate us about this. Brief introduction. He hates fruit, he hates vegetables, he loves ribs. He is Scott Lee. Thank you.
I should really moderate the afternoon session. So I get all of my disparaging comments out in the morning and they come back to bite me in the butt in the afternoon. This is my introduction slide. I have some disclosures. I'm very conflicted. So, as usual, couple disclaimers to my talk. I get to, since Ghassan, myself, and Paul were organizing this, we get to kind of cherry pick topics. I usually cherry pick the topic that has limited data because I don't like to look at data. It's hard for me to understand. I don't have to do research. I get to just spew out things and then people go, well, there's no data. And I go, exactly. Second thing, you guys don't know how OCD and difficult it is to work with Ghassan. We get to slide review and he's like, that font is different. I'm like, oh my God. I am not a millennial. I don't care about the font. So then everyone in the room is like, oh, all you have are words. Oh, we want like emojis and I don't know, whatever they put in. I go, no. Okay, first of all, my slides suck. I admit that, okay? They're words. And apparently people don't read anymore, so they're words. But again, the slides are here. I have like, I don't know, 30 slides. I'm going to get through it in 15 minutes. The slides are, to me, a vehicle. They're there for your reference. You want them. You want the references. Email, you'll get the slides, okay? You guys are here for this. Right now. This is what you're here for. Not this, okay? So, see that? I just won $50. So, Eric said I wouldn't do it. You guys know I'm 1% joking. Really, slides are slides, right? So here we go. So what is conventional therapy? Mike Curian gave us a great talk on mesalamine, azathioprine, methotrexate, right? So that's what we always have considered conventional. Whether you want to call it advanced, whether you want to call it biologic, which is now going to fade, right? Biologics are no longer our only advanced therapy. We're going to get a wave of small molecules, and it's going to get increasingly confusing. We're finally getting to an era where we're starting to see head-to-head trials because we'd always say, I don't know, you can't compare across trials, the data looks similar, this drug looks similar, safety looks similar, yada, yada. So when we talk about in 2019 beyond conventional, it's anti-TNF therapy. You can see we have 4 of them approved for IBD, right? Infliximab, adalimumab approved for both UC and Crohn's. Certolizumab, golimumab. Certolizumab is approved for Crohn's, golimumab approved for UC. We've got vedolizumab approved for UC and Crohn's, right? Alpha-4 beta-7. We now have ustekinumab approved for Crohn's, should get approval for UC. The New England Journal data is out there 2 weeks ago, roughly. So that will be coming as a UC-approved drug soon. Tofacitinib are JAK inhibitors, small molecules, right? Newest kid on the block, only approved for UC. They're not going to go for a Crohn's approval. They had 2 phase 2 trials that did not meet endpoint. I'll come back to that. And then there's natalizumab or Tysabri, which again, very few people are using in IBD. It's only approved for Crohn's, but because of the risk of fatal brain infection, we don't use a lot of that, okay? And I think the biggest thing here is we don't have a predictor, right? So a patient comes in and goes, well, which one, doc? And I go, right? I don't know. What do you want? You want a pill? You want to infuse? You want to inject? You want both? So it really comes, we cannot pick out, pediatric patients are better on TNF or, Vito. We don't know that. So we're really left with, well, how are we comparing these drugs, okay? So, and I think the way to look at this is safety, is really what patients care about is safety, right? I think they all believe this drug could work for me beneficially, but it's really about safety to them. So anti-TNF therapies have been around forever. Again, lots of words. I know no animations for Wabe, but that's fine. So most of the IBD anti-TNF therapies, they look similar. No one's done a head-to-head. Let's take adalimumab and compare it to certolizumab and see who wins in Crohn's, et cetera, okay? All of them treat multiple diseases, right? So most of them are approved for multiple diseases beyond Crohn's and UC. So they got RA, they got psoriasis, ankylosing spondylitis, et cetera, et cetera. So these are a class of drug that can work for multiple autoimmune diseases, okay? And I would say this about all of the biologics. To date, we don't have any dose duration toxicity. So what does that mean? It means you're on anti-TNF day 1, a year, 10 years. You've doubled the dose, tripled the dose. There's no toxicity that goes along with that. But you guys know that's not true for small molecules, right? Prednisone, 60 milligrams, more side effects than 10. a year's worth of prednisone, which you should not be doing, a lot more side effects than 2 weeks of prednisone, okay? So biologics don't have dose duration increased toxicity. The relative contraindications in anti-TNF therapy is opportunistic infections. You have heart failure class 3 or 4, demyelinating disease, right? The one we know is multiple sclerosis. So patient comes in and goes, oh, by the way, I have MS and I just got diagnosed with Crohn's. TNF is not your ideal mechanism of action. And then chronic viral hepatitis. I'll touch on these a little more in depth, but as I mentioned, this is for your information. Remember I said, okay, class 3, 4 heart failure, we probably shouldn't be prescribing anti-TNFs. This is because you can see that there's a trend. The higher you go on this, which I don't believe is necessarily a dose response. It's probably, it's a statistical anomaly, but basically it's worse than placebo in most arms. You can worsen heart failure. Again, most of the time you stop the TNF, the heart failure will go back to its baseline. Cardiovascular events, this is another for your reference. This is what we see in trials, right? We don't see higher rates of MI. So this is, you have existing heart failure, maybe not a good idea, but we're not causing myocardial infarctions. Neurologic events, again, for your reference, we see peripheral neuropathy. We've diagnosed people with multiple sclerosis, optic neuritis, peripheral neuropathies, right? So patient complains to you, hey, my vision went out. Probably send them to a neurologist, unless you're a gastroenterologist that wants to deal with this. I'm not sure why you would, right? So we take this seriously. If someone comes in and goes, oh, my left leg falls asleep all the time. I'm like, I don't know. I guess I should send you to a neurologist, right? I couldn't figure out how to do a neurologic exam if someone paid me, and no one does. So, again, post-marketing, these are the things we worry about. Heart failure, I don't particularly worry about increasing the risk of lymphoma with anti-TNFs. Other malignancies are really kind of at the baseline. So again, it's really heart failure, opportunistic infections, neurologic complications, okay? So we should worry about those. These are the opportunistic infections. Do you have to remember this? No, just anyone on an anti-TNF, vague, I got fever, I'm losing weight, but you tell, their colitis or their Crohn's is in remission. You got to start thinking, do we have some opportunistic infection which is going to present atypically? Okay, so long-term risks. I do believe there are 2 long-term risks with anti-TNFs in particular. One is psoriaform rash, right? This is not psoriasis. Anti-TNF treats psoriasis. So this is probably a dose duration toxicity. It can happen with any anti-TNF. It's about a 1 to 3% chance, if you will, and it tends to happen later in disease cycles. So, hey, I was on adalimumab for 4 years, didn't get it. Now I'm on infliximab. Well, it's probably that cumulative anti-TNF exposure, okay? Our experience has been that if you go from one TNF, you say, well, you got this psoriaform rash, you go to another, 50-50 chance if it comes back, okay? Our experience has also been that if you treat them with topical steroids, topical tacrolimus, or you add azathioprine or methotrexate, which we've kind of talked about that we're not doing long term, half of those patients you can get to stay on their drug, the rash will be reasonable or resolve, okay? And then the second one is sensitization. It's not really a direct effect of the drug. It's probably us either not following these patients carefully enough and watching their dosing, they get antibodies, right? So they get allergic reactions. So again, 2 side effects that are dose and duration that are not, again, the psoriasis is probably a direct effect, but we don't understand it because it's an uncommon event. So with that said, the summary of anti-TNFs, in my opinion, is most of them are similar efficacy. They are now actually becoming kind of our older therapy. So I don't think anyone's going to do a head-to-head, right? And I'm not talking about biosimilars. I'm talking about head-to-head of adalimumab versus certolizumab versus infliximab versus golimumab. So we're not going to see that. But in general, we think risk is similar and efficacy is similar. Watch out for the psoriaform rash. Watch out for sensitization reactions, right? We all seen this, allergic reactions, rashes, anaphylaxis. And then again, you have a patient that says, oh, by the way, I live in an area where everyone has TB. Probably not the ideal therapy. I've got horrible heart failure, not the ideal therapy. I have a history of MS. Again, you want to avoid these. And then the only good thing about me working at UW is these patients, I get these hepatitis, I'm like, okay, they go, what do I do now? I go, I don't know, go see the hepatologist. In your guys' clinic, that's usually the same doc that diagnosed him with UC, not mine. So you probably want to talk to a liver specialist or think about, again, that's a relative contraindication. If you have chronic Hep B, Hep C, not so much, but chronic Hep B you want to watch out for, okay? Again, diagrammatically, right, we always throw these up. Hey, look at all these potential mechanisms we're trying to block. But really, what we're going to talk about is vedolizumab, which is alpha-4 beta-7, and then ustekinumab, which we'll come back to, and then JAK inhibition. So somebody tell me what they see here. This is an eye test. No, again, for your reference, I'm not going to read this to you, right? So basically what I focus on, if you've ever done clinical trials, right, it's quite fascinating. Anything that happens in a trial, and we don't know because we're blinded. So a patient gets in a car accident, you're like, well, that's an adverse event. Like, I don't think that's because you're on vedolizumab, but sure, we'll log it down. Right, so all of those things end up in here. I got the flu. Well, you're on placebo. It gets checked off. So you can see the main point is there is no signal for infections, any real adverse event of clinical significance that you can see in higher rates in a population that started on vedolizumab versus placebo. And that's really the main point of this slide. Again, this is a different way to look at it. I'll let you peruse that. But basically, the point I take away from this is we don't know that there is any signal for infection, cancer, or other things like heart failure, demyelinating disease with vedolizumab. I think most people in the IBD world consider this one of the safest therapies we've ever had. Right? But they went further, right? They said, well, are we better than anti-TNF? And I think part of this was the world kind of saying, well, you know, Vedo, it takes a long time. Do you have time to wait? And so they went against adalimumab, right? So this is recently published about a couple of months ago. So this is called the Varsity trial. So take patients who've never been on adalimumab, take patients never been on vedolizumab, randomize them. They're getting one or the other. And you can see at the end of the year, 52 weeks, right? So we end up with numerical and statistical superiority, overall population for remission. If you look at the anti-TNF naive, it holds up. And then when you go to the ones that had previously been likely on infliximab, it kind of falls apart a little bit, right? But we know once you've exposed a patient to an anti-TNF, if they failed it for whatever reason you want, insurance, antibodies, just primary non-response, when you go to your next biologic, it's not unique to, oh, I'm going TNF to TNF or TNF to alpha-4 beta-7. I think it's a predictor. You did poorly with one drug, you don't respond. That's predicting for us that you have worse disease, less responsive. So you can see that if you've been exposed, this kind of doesn't hold up quite. But basically, the end result, if you take the overall population, is vedolizumab was superior in this population of achieving remission. And this is just to say, well, because everyone said Vedo is really slow, anti-TNF is as fast as corticosteroids, you can see in this diagram again, the blue line is adalimumab, right? And it's basically when do these patients achieve response. And you can see the orange line lags at the 2-week, but then it passes it shortly after that. So again, I've never been a big fan of I need to have a patient in remission in 2 weeks, right? And this is a lifetime disease. So, but now vedolizumab has been able to show we're not slower than an anti-TNF therapy. So again, maybe Vedo is a very good option. So the summary is this is okay for both biologic naive and exposed. It has been shown to have improved safety, which I didn't show you, and efficacy over adalimumab. Again, so same considerations, right? We don't see TB, opportunistic infection, so not that you're excited about giving someone with an active infection any of these, but it's not a contraindication. Heart failure, psoriasis, MS, not a contraindication, but this drug is unlikely to treat psoriasis, RA, other things that we normally would think of, right? And it doesn't treat MS because it is not associated with PML because it doesn't cross the blood-brain barrier, but even more importantly, it doesn't affect the cells that want to go to the blood-brain barrier, okay? Rapidity of onset, I've just shown you, it looks like it's probably similar to at least adalimumab. Immunogenicity is less with this class of drug than it was with anti-TNFs. Anti-TNFs by monotherapy at the end of 1 year is usually about 20%, right? If people have antibodies. Vedolizumab is about 4%. So this is for us in our clinic, mostly monotherapy, not doing AZA, not doing methotrexate. Right now, it's only an infusion, probably January, unless the FDA does something very odd, we'll have a subcutaneous every other week injection of this also. So what is the cost? Again, we could talk about that until the cows come home. But again, I think the main downside of Vedo, it's super safe. It looks like it's superior to adalimumab. Again, we're not talking, 100% remission, but it doesn't treat other autoimmune diseases. So you have a patient with psoriasis and IBD. Maybe this isn't the right therapy for them, but for pretty much everyone else, it's a great, safe therapy. Ustekinumab came out 2 years after vedolizumab. You guys can look at how it works. Again, main thing my patients care about is the safety. So what do we see? it looks pretty much like vedolizumab, right? No signal of infections, right? I won't say that the higher dose group had the lowest infections that we're protecting. No. Adverse events, there's always in placebo group a fair number of adverse events. They tend to be disease related, right? So Crohn's gets worse, so they drop out. Again, malignancies are the same. So again, in my opinion, vedolizumab and ustekinumab, similar safety profile. No one's done a head-to-head, so we're looking at comparing across trials. This drug does not have comparative efficacy, okay? But it is effective for induction, remission, biologic naive, biologic exposed, okay? They are going to get UC approval very soon. I did not put that up here because it's not approved yet, but it will. The dosing will be the same. Again, same as vedolizumab. We don't see TB. We don't worry about CHF. It will treat psoriasis, right? But not RA. I've found this to be a very terrible rheumatoid drug. Immunogenicity is probably the lowest we've seen in biologic studies to date, 2.3. So again, monotherapy, 1 infusion, every 2-month injection. Cost is high. Okay. So with that, I'm going to segue very quickly into small molecules, which is going to be the next wave that's coming. Okay. The difference is small molecules do probably have dose duration related toxicities. Okay. The longer you're on something, the higher the dose you go, you're probably going to start seeing signals of adverse events. You also see signals of increased benefit, but it's the adverse events that stop us from just going up and up and up on small molecules, okay? They're cheaper to produce. They're still going to be expensive, okay? This is JAK inhibition, again, cartoon for you guys to look at if you're interested in how these things really work and what they inhibit. We're going to be talking about tofacitinib, which is the only JAK approved for ulcerative colitis, not for Crohn's so far, okay? And it won't go for Crohn's, but there are JAK inhibitors that are in Crohn's studies right now. Again, most patients believe this works. The adverse events is what they're concerned about, right? So we do see a signal of, on this is the general, right? Nasopharyngitis, upper respiratory. It's a little higher, right? So the 10 milligram BID is 14%. The placebo is 5.6%, and the 5 milligram dose is 10% up here, right? So there is a slight signal of the higher we go on the dose, we might start to see common infections. What really is standing out to us is serious infections, and the main one here is shingles, right? Varicella. So we've heard about the vaccines. I think the main issue with the shingles for me is get your patient a vaccine. And the vaccine is dead inactivated. It's not live, so it can be given to anyone. They're on prednisone. They're on another thing. So if you're going to go towards tofacitinib, you should really strongly consider giving them the Shingrix vaccination. That is off-label because it's only approved for immunocompetent people above 50. But there's no reason I know of that I would suspect that it would cause problems, okay? The rest of the things sort of fell by the wayside. There wasn't a strong signal, but if you guys read the papers, you get internet, right? There was a recent new black box warning, and this is a complicated one in my opinion, right? So it was an RA study. They enrolled patients on 10 milligrams BID, which was not the FDA-approved dose, but we can talk about why they did that. The 5 milligram BID, which was the FDA-approved dose for rheumatoid arthritis, and then they compared it to adalimumab, okay? And basically, they were wondering whether there would be cardiac events. And halfway through the study, the unblinded safety team said, hold on, we're seeing a little bit of a signal. So it showed increased occurrence of blood clots and death in the 10 milligram BID group. Again, it's RA. And these patients all had to either have had a thromboembolic event, a cardiac event documented before, or they had multiple risk factors. So again, not really our population. But it's still, data is data, right? So they said, 19 cases of blood clots, I can still do some math, which is the bottom line there, right? So, and then 3 out of 3,982. So if you were on 10 BID versus adalimumab, you have about a 6-fold increase of developing a thromboembolic event, okay? Deaths, which is all causes. Could be infection, could be thromboembolic, could be cardiac, right? So 45 out of 3,884, 25 out of 3,982. So it's about a 2-fold increase. So the FDA said, oh, we got to say something. So they said, basically, you should take your RA patients, counsel them about this. You should probably take your RA patients that are on the higher dose and drop them if you're there. For ulcerative colitis, they kind of said, you got to talk to your patients. We're not sure what to do with this because it doesn't necessarily pertain. And basically the way I look at it, so the bottom two bullets are me, is IBD patients we know, right? So colitis patients have active disease. They have a very high risk of thromboembolic events, up to 8-fold, up to 12-fold in some studies. And so again, if we go back, my back of the napkin calculation for these blood clots is about 6-fold. Okay, so you have a severe colitic, failing whatever, or doesn't want to be on a biologic. They have an 8-fold risk of blood clot. Are we really going to tell the patient, hey, look, we're going to put you on tofacitinib and you're still going to have a 6-fold? That doesn't make sense to me, right? So you're lowering their risk of thromboembolic events theoretically, and you're controlling their disease so their quality of life is better. So in my practice, this has not changed the use of tofacitinib. I joke with Kindra, she always wants to dose reduce people. Sonia, she left, I think, she wants to dose reduce people. And the only people we're dose reducing or that I want to dose reduce are complete endoscopic healing. Everyone else I say, look, just stay there. I'm not sure that this risk really is something that is worthwhile dose reducing. Okay, so summary of tofacitinib, no comparative efficacy, right? No one's going to compare that. It does work for induction and maintenance of UC. It has a rapid response, okay? My personal opinion, again, that's me. I think it does work for Crohn's. Half our patients that we put this on are Crohn's. It's just, we can talk about why they're not going to do it. It's a financial, logistical, it's a whole bunch of things. But so again, with this, the major safety consideration that we can intervene on is varicella. Give them the Shingrix vaccination, or at least give them acyclovir, valgacyclovir to have sitting in their shelf. They get a rash. That's what we do when patients go, my insurance won't pay for the shingles. I go, fine, here's some valgacyclovir, they'll pay for that. Keep it in your medicine cabinet. You get a rash, start taking it, call me, take a picture, send me the picture, okay? What's different about this, other than the thromboembolic events and cardiac events, is it doesn't have immunogenicity, okay? So, hey, I didn't take it for 6 months, now I'm flaring. We don't worry like we do with the biologics. Well, you have antigens, we got to get you off of this, correct? So you can interrupt, not desired, but it can be done. So again, we've gone over this. This is the summary. And the last slide I really want to get to is, okay, so if you're going to choose one, if you're choosing on safety, I'm not saying every patient chooses on safety. Some of them choose on convenience, right? So Veto and ustekinumab probably our safest drug. TNF and TOFA, they're different risks, but they're probably on par, okay? TOFA is associated, it's the only drug we have associated with possible MACE myocardial events, right? Or VTE. So, and then anti-TNFs, you gotta avoid MS, CHF, opportunistic infections. So if it's safety, Veto and ustekinumab come to the top. If it's efficacy, the only head-to-head trial we have, and it still doesn't predict who's gonna respond, is Veto versus adalimumab, and we can say that in one trial, Veto beat adalimumab, okay? We're not going to see a lot of other head-to-heads in the near future. It's gonna take us years. TOFA can treat RA, anti-TNF can treat RA, psoriasis, okay? So again, you have a patient with multiple autoimmune diseases. If they're the ones that respond, then pick one that crosses over. And then if it's convenience, that's in the eye of the beholder. Some prefer pills. I've had patients, I go, look, you're naive to everything. Here's all this stuff on tofacitinib. They go, great, that's fine, give me tofacitinib. I'm like, you heard me say, right? Blood clots and shingles, and they're like, hey, give it to me. So if you're choosing on sensitization, which really is non-compliance, right? I don't believe you're gonna take this medication, so I believe you're gonna intermittently use it, and then you're gonna get anaphylactic and permanent loss of response. We'll probably choose TOFA, or if you wanted a biologic, probably choose ustekinumab. And I am over my time. Why is that there? Oh, we don't know the sequence. So nobody has any idea what patient should get TNF first, what patient should get Veto first, what patient should get ustekinumab. We just don't know. So it really comes down to what your comfort is, what the patient's comfort is with the safety, what they want to do logistically. And then the reality is, it's insurance, right? And we're going to have a whole talk on obtaining one of these things in a moment. Sorry for the going long. Coming up, Gassan. Thank you much.
Thank you, Dr. Lee. I want to invite the panel to the podium.